Hi, back with another session here. Here we'll learn about PID, which is pelvic inflammatory disease, which includes infection and inflammation of the upper genital tract involving fallopian tube, uterus, ovaries, not involving the cervix and vagina. So, cervicitis and vaginitis are not a part of PID. They are actually in the lower genital tract. So, the infection will ascend upwards from the cervix and vagina to the uterus inner lining, which is endometritis. In fallopian tube, self-anxiety. In ovaries, it is ophoritis. In pelvic peritoneum is pelvic peritonitis, and maybe sometimes in the pelvic cellular tissues causing the parametritis. So, causes, it can be like due to polymicrobial infections, so caused by a variety of various of organisms, can be remembered by can, is chlamydia trachomatis, which is the most common organism causing PID. In the IUCD users, which is intrauterine contraceptive devices, actinomycetes organism is most common there. Neisseria gonorrhoeae and others include Mycoplasma genitalium, E. coli, which is most common in the postmenopausal females and most common cause of PID in virgin females, genital TB. So next one is a sign and symptoms. You have to like remember with minimum, additional and definitive criteria. So in minimum criteria, tenderness, word is common, lower abdominal tenderness, adnexal tenderness or cervical motion tenderness. Additional criteria includes elevated ESR, CRP, which is the indicator of infections, temperature. Temperature, mainly the oral temperature, will be raised more than 101 degree Fahrenheit or more than 38.3 degrees Celsius. Then lab documentation of the cervical infections with Neisseria gonorrhoeae or the chlamydia trachomatis, presence of abundant number of WBC, on saline microscopy of the vaginal fluid, abnormal discharge, cervical or vaginal mucopurulent twitches mainly. In the definitive criteria, you can see laparoscopic evidence of PID, histopathologic evidence of endometritis on biopsy, on imaging study TVS or MRI, there will be evidence of tubo-ovarian complex. Then in complications or effects, you can remember by mnemonic EPIC, which is EP stands for ectopic pregnancy, I for infertility, C is chronic pelvic pain, and other one tubo-ovarian abscess. For diagnosis, you will first examine the patient on that bilateral lower abdominal pain, also with the vaginal discharge. ESR, CRP, WBC count will be raised. Pregnancy test you have to do to exclude the ectopic pregnancy, because ectopic pregnancy is differential diagnosis for the PID. On laparoscopic, which is a definitive test or a most reliable method to diagnose PID, you will see the pus is coming from the femoral end, and the additions you will see on the laparoscopic, which is a definitive sign of PID, pelvic inflammatory disease. Other side, maybe you will see hyperemia and edema of fallopian tubes, adherent tubes, like that. Then management. According to CDC criteria, you can treat the patient on an outpatient basis based on the severity of symptoms and inpatient basis. So outpatient, regimen A, in which we have to give ceftriaxone by IV route followed by doxy with or without metronidazole for 14 days, which is oral. In regimen B, cefoxitin you have to give, and this cefoxitin you have to give like IM route along with probenecid. This probenecid is orally, which is given concurrently along with the cefoxitin with doxycycline with or without metronidazole for 14 days. So inpatient basis, when you will treat or when you will hospitalize the patient, so for that indication, some indications are there, like if the patient is pregnant or there is a tubo-ovarian abscess, or maybe some surgical emergency, so you cannot treat the patient on outpatient basis in that cases, or a severe illness case, or a patient is unable to follow up and tolerate the OPD regimen, no clinical response to the oral antimicrobial therapy. In that case, you will give that IV thing. So regimen A, cefotetan or cefoxitin with doxycycline, oral or IV, every 12 hours, first regimen. Then B regimen is clindamycin IV with gentamicin IV or IM, loading dose followed by the maintenance dose. If you want a detailed lecture on PID, do comment. Thank you.